Hi there, my name's Caelan Taggart. I'm one of the cardiology research fellows from Edinburgh, working with Professor Mill's team. My project will be on looking at the application of the universal definition of MI in practice. So we've had plenty of history lessons today, so here's another one. As we know, over the last 50 years, the definition of MI has changed drastically. We've kind of come from very unspecific transaminases with the clinical presentation in ECG to kind of now with the more advanced development in biomarkers, as you can see in the timeline here, to the universal definition of MI. And I think in the last 20 years we've been given the unique opportunity to try and unify the definition with the underlying mechanisms of disease and thus subgroup patients into types of MI in order to try and treat them based on the same kind of categories of treatment. And we can see there's 5 subtypes now. You're probably all very familiar with this, but atherosclerotic plaque rupture, type 2, which is less understood, and there's less, even though it represents about 20% of MIs, there's actually no guidelines to guide care really yet. 3, 4, and 5 we'll not get into detail, but are sudden cardiac death and PCI and cardiac surgery. But really, this has been out for about 15 years now, and we don't know exactly how this is being, if even, applied in practice, and whether or not clinicians are listening to the ESC guidelines to do this, and is it going to make a difference? So my questions are really, do patients who fulfill the UDMI criteria actually receive a clinical diagnosis from their clinicians in hospital here treating them, and is that in the notes? Is this applied across different healthcare settings, and are even subtypes of MI even being recognised at all, such as type 2 MI? So yeah, the aims are to evaluate the application of the universal definition in practice across different healthcare settings, and the other one was to look at different clinical characteristics and outcomes in patients who didn't receive a clinical diagnosis from their clinician who we felt met UDMI criteria for a diagnosis of myocardial infarction. So we used 2 large multi-centre studies of consecutive patients with suspected ACS. No shocker, high stakes being one of them, which was across 10 hospitals in Scotland, and another cohort from Sweden, but we'll talk about that in a while. We adjudicated all diagnoses of suspected MI across both, with 2 cardiologists, with a third if there was any disagreement. And then we had the unique opportunity within our healthcare systems in Sweden and Scotland to look at the codes that were given patients for their diagnosis from their clinicians. So in each hospital you get a discharge letter that's looked at by your consultant, and then a team of coders swoop in and give you a diagnosis that's then put under the public health records. So we had a very unique opportunity of getting hold of that, which was very helpful. So this is our study cohorts. I'm very familiar with the one on your left, my right, of the high stakes. However, this was a study looking at whether or not high sensitivity troponin improved outcomes in patients. So we had to exclude the patients of which a contemporary troponin was used by the treating clinician for a diagnosis, which left us with 28,000 patients for adjudication. And if we look at the bottom here, once we adjudicate all these, we ended up with about 3,100 type 1 MIs, 700 type 2s, and about 1,700 odd non-ischemic myocardial injury patients. We also were lucky to gain hold of a cohort from Sweden of 22,000 patients. Unfortunately, when this study was designed, they excluded STEMIs, so we couldn't include that in our final analysis. We didn't have that data available. But that left us still with 21,000 patients, of which there was adjudicated diagnosis by the Swedes of 1,000 type 1s, 250 type 2s, and a lot more non-ischemic injury, probably reflective of the use of the Roche assay over the use of the Abbott IE assay, which was used in Scotland. So we decided to use several methods to measure agreement and use of clinical diagnoses. First was just between the UDMI adjudicated group and clinical diagnosis. We used a simple confusion matrix. I say simple confusion matrix, that's probably a bit of an oxymoron, but developed Kappa agreements and looked into that. We looked at the characteristics of those receiving a clinical diagnosis, so how likely, what sort of features made it likely for your clinician to think you were having an MI over not, compared to our gold standard of adjudicated cases. And looking at the outcomes in those receiving a clinical diagnosis versus who didn't in both groups. So these are some sunburst plots that I've made. Is there a pointer here? So to try and explain these, in the middle here we see this inner circle. This represents all the myocardial infarctions type 1 and 2 in the Scottish cohort and the same in the Swedish. If we look at how these are proportioned up, interestingly, it was exactly the same, 82 and 18%, divided also 18% type 2s, 82% type 1s. But if you look at the outer circles, this looks at those who actually then went on to receive a clinical diagnosis in their hospital record. And shockingly, 83% of those with a type 2 MI had no mention of myocardial infarction or a diagnosis of that from their clinician in practice. And this was actually the same in the Swedish cohort with 77%, a little bit better. If you look at the type 1s, however, we're a bit better at this. 79% of those who we adjudicated as a type 1 had a clinical diagnosis in their hospital records, a bit better in Sweden at 87%. However, is this good enough? Should we really be picking up a lot more of these? Because even though the numbers are good, should we really kind of be picking up all MIs in practice? But unfortunately, we don't. And yeah, so this is just a reminder of how many MIs there were in both groups as well going forward. Right. So yeah, when we look at the sensitivity of gaining a clinical diagnosis from your gold standard adjudicated, it was moderate in the for type 1s in the Scottish cohort at 78% and pretty abysmal for type 2s. So we're not really picking up any, less than 1 in 5 type 2s really are being recognised clinically. With good specificity, meaning that people that we adjudicated with a type 1 also were receiving a clinical diagnosis, and so there was good specificity for type 1 and 2. And the CAPA agreement is reflected for type 1, it's pretty poor for type 2. And we can see this is also the case for the Swedish data with very, very similar results. So if we look at the clinical characteristics, first of all, in type 1 in patients who receive a clinical diagnosis in Scotland compared to those who don't, you can see that actually, older patients are less likely to receive a clinical diagnosis. They were more likely to be female than their clinical diagnosis counterparts, which were, if you keep in mind, this is a predominantly male population of suspected ACS. And troponin, as usual, was very predictive of receiving a clinical diagnosis, which is no shock, I suppose, when you see a patient with a high troponin, you think this is an MI. In type 2, however, there wasn't really any statistical difference in age or sex. However, troponin remained a strong predictor in you getting a diagnosis by your clinician in hospital of myocardial infarction. So yeah, and if we look at the odds ratios for this, age again is, and it is statistically significant, and sex both, and this is adjusted for numerous cardiovascular risk factors such as ischemic, actually it's adjusted for previous ischemic heart disease, stroke, diabetes, and troponin actually, and a few other things. And troponin remained also predictive of this. Not statistically significant in Sweden, but again, I think this is just reflected by the lower numbers of outcome events, and you can definitely see a trend here in both, and they're both very, very similar, with troponin also being predictive of future, of having a diagnosis in your notes. Type 2, no shock, we've seen in the characteristics table that age and sex didn't really have any bearing over whether or not you received that in your notes, but troponin was quite predictive, and I suppose that might be indicative of the fact of a real supply and demand imbalance, and we're picking that up in sicker patients, meaning they're more likely to be recognised as having a MI in practice. So here's a couple of cumulative incidence plots looking at both populations in Scotland on the left. So interestingly, patients who we adjudicated as having a type 1 MI in our cohort but didn't receive a diagnosis in their notes from their clinician is represented by the solid line here above, and those patients did worse. And we think of the reasons for this, and I wonder, was one of the things we thought is, are patients, are clinicians ignoring these smaller troponin concentrations, which we can see in our clinical characteristics these patients do have. But we also delved further into the data and looked at the incidence of coronary angiogram and cardioprotective therapies, and these patients got consistently less of both. If we look at Sweden, there was a similar story. There was no statistical difference in whether or not you received the diagnosis or not, but if you look at the graphs, the Swedish cohort excluded MIs up to 30 days, which I think has kind of changed the data, but I still think it's important that there's no difference at all, and these patients also had less cardioprotective therapies and less rates of angiography and PCI. For type 2, if we look at patients that received the diagnosis in their notes, they had worse outcomes, and I think that's to be expected. You normally pick up a type 2 when there's a clear presentation of supply and demand imbalance, and the ones where that aren't that sick and you mightn't be able to gain up that ischemic threshold are less recognised. So to conclude, the universal definition we don't think is consistently applied in practice, with only less than 1 in 5 patients with type 2 identified. Type 1 myocardial infarction is under-recognised in women and in older people compared to if you apply strict criteria. And I think these observations were similar across different healthcare systems, suggesting that uncertainty remains as to the use of the diagnostic criteria in practice. So I'd like to thank all my team, especially Dorian, who helped me out a lot with this project, and all this team in Sweden as well.
So on the right side, this looks a little bit like German beer. Yeah, very nice presentation. So do you have examples where there was a difference in clinical diagnosis and also the adjudicated diagnosis? Because for clinical practice, for me, I would say it's very easy. You look for the troponin, you look for the ECG, you look for the symptoms, and then you make the diagnosis of type 1 or type 2 myocardial infarction. Why is it so different?
Yeah, it's a good question, and one we've been trying to discuss and answer in our just recently submitted manuscript about it. But there's things that we thought about is, yeah, you don't have the full patient in front of you when you're adjudicating notes. And you also have to consider things like unstable angina, and and whether or not providing a diagnosis of MA is truly helpful in terms of going forward. But unfortunately, outcomes were still worse, so maybe that's not the reason to do it.
Any further questions?
Yeah.
Maybe you can bring the mic.
Thank you. But part of the problem with this is if you looked at the retrospective whole patient cohort, is that of why a troponin was done. So often, particularly in elderly patients, it's of absolutely no utility whatsoever. You've got an old sick patient who is probably dying and someone does the troponin. And it's just like, well, that doesn't help me. I know that they're old and they're sick and I'm not going to do anything anyway. So to what sense do you get that from the cohort? And what I'm coming to is that choices are made about patients is not really, as you said, it's not actually that helpful to me put a label on some of these patients because I'm not going to do anything anyway, and the troponin should probably have never been done.
Yeah, excellent question. I think it really comes down to the word suspected ACS, and that sometimes is thrown around a bit loosely these days in terms of when an actual clinical indication for troponin is. And yeah, it would be great if we had the data to look into the reasons why, and I think going forward with data that we're collecting, we do try and grab that now, and we've had a few qualitative studies in the emergency department looking at why SHOs, etc., take troponins and what the indication is.
Okay, I think we move on. Thank you very much. Very nice presentation.